everybody to this webinar concerning the sacroiliac joint. What, why and how is the little title I've put on it. What is it? Why is it there? And how do we deal with it and test it and fix it and such like. What I'm going to start with, if I can get the computer to advance. Get out of day, we've only got, an hour, and of that, some of it has to be questions. So there's a lot to fit in a small time. So a lot of it's about getting your thought process going, getting you think about where else you can go for further information, and really directing, like CPD, where you need to go and taking some of the uncertainty about what do I need to know and what don't I need to know out of this. And I've used the word to simplify and condensify a plethora of information, and there is. If you type SI joint into Google, take your pick, you'll be there all day, but what you'll find is there's a lot of repeated stuff and there's a few odd bits, and it's sometimes hard to pick out what you need. So one of our aims today is to really just simplify that down and identify what it is you actually need to know, whether you're super experienced or whether you're just coming into this. There's so much value in always going back to the basics, the mechanics of how things work, and not always getting too complicated. The answers to most problems are in a good understanding of the basics that you learn right back at the beginning and then forget. Or you learn at the beginning and think, I need to move on now to learn stuff that's even better. So let's get that nailed down best we can. We're going to get an appreciation of the function. I could go on all day about function. I could go on all day about tests. I could go on all day. So we have to consent it down. I'll show you a couple of ways locating the SI joint if you struggle with that. I want you to appreciate what it is about dysfunction, because there's not much dysfunction that occurs in the SI joint. So let's be clear with that. And what you can do, both from a therapy point of view and an exercise point of view, and of course a combined point of view to help it, and we'll run along some of the medical strategies that people come up with on the way. So let me introduce you to the sacroiliac joint. Wave my cursor around, there it is, just there on this rather odd 3D body image package we have, which is slightly misshapen. You will hear, if you do choose to do a little bit more reading or a little more, lots and lots of terms about the SI joint and what type of joint it is and what it is. And forget it. What we need to know is it is a synovial joint. It has a hyaline cartilage. It has a joint capsule. It has nerve endings. And because it's a synovial joint, it has movement. And any joint that has movement has the ability to suffer wear and tear, tighten up, get too loose, and all these kind of things. So don't worry about the odd little descriptions you hear of it. It is fundamentally a synovial joint. How much movement it has, and the whole thing with the SI joint and the whole thing with research around the body, is none of it is particularly conclusive. There is movement available. Of course there is. It's a synovial joint. You wouldn't have a synovial joint without movement. It would be a pointless part of your body. 2 to 5 millimeters, they say. And then you'll start to hear little things about certain directions. It moves in every direction. It will rotate. It will slide. It will go anterior and posterior. It moves all over the place. And it wouldn't surprise me, as investigative techniques get better and better, if we found it moved an awful lot more than that. A lot of these studies are done on cadavers, and then you have problems with tissue that has become tight and other things. So yes, it's a movable joint, and we want it to do that within reason. Its functions, if you're wondering why it's there: spreads the loads, it transmits the loads that you get from the upper body, that is your body weight, and also anything you're carrying, anything you're lifting in the gym, and it puts it down into the legs, which is important because otherwise we wouldn't be able to walk around with things, we wouldn't be able to carry heavy items, we wouldn't be able to throw an antelope over our shoulder when we're hunter-gatherers and walk back with it. However, of more interest to us is not about the transmission of forces, it's what it really does. It's a buffer zone in both directions, basically. If you get a sudden load on your upper body, it actually, to a degree, absorbs some of the impact that could come down through into the hips, into the legs, into the knees, but it works the other way. When you walk, when you run, it's a buffer zone that absorbs some of the impact that comes up through the ground that we don't really want to go up into the spine. Having said that, for those of you who have been on our sort of gait courses and our foot mechanics courses, you'll know that if your feet are behaving correctly, actually the forces don't really leave the foot anyway. But in most people in the real world, they do. So a good function SI joint is quite important in protecting the back. Gives us mobility, basically, when we walk. It allows each side of the pelvis, if we go back to that picture there, if we didn't have the SI joint, this would be one great big bone with two hips stuck in the bottom of it that would swing backwards and forwards. And this bone wouldn't move, it would just rock. And you'd walk a bit like a bear or an ape. So it allows each side, the ischium, it allows the ilium to, not the ischium, so the ilium to move left and right and rotate as you walk. It gives us some general mobility. And you can think of it in a way of look at what your shoulder girdle does as you move around. Imagine if your scapula didn't move. Imagine if your scapula was just fused to your spine and it never rotated forwards or back or angled away from your spine. All your movement would have to come from the glenohumeral joint. This is very much the same way to think with the SI joint. If that joint does not move, then we have to take excess movement through our hips. We have to take some excess movement through our lower spine. And those have obvious implications in terms of pain and discomfort. So it just keeps the whole thing mobile and moving. Have a little look at some of the things that can affect it. We've got the nerves on the picture here, and I haven't picked one nerve because there's so many of them, but look where these nerves pass. Very, very close, especially down here to the SI joint, especially the sciatic nerve. If the sacroiliac joint becomes inflamed, if we've got some degeneration or a problem there, then that localized inflammation can start affecting the nerve, which is why you can start to get nerve referrals from SI joint problems, why you can mistake them and they can mimic spinal problems. We'll also have a look in a minute at, look at the level of it. Basically, it comes in, the SI joint really is on the L5-S1 junction, basically. So problems here and problems actually in the SI joint can be very difficult to tell the difference between, but we have got a few ways of doing that. And there's lots of things it can mimic, really, but just be aware of how many nerves go around it and near it. And this is from the back. Now we're looking at it from the back of the body. Look at these little nerves here where my cursor is going. Okay, those will pass under the glute and into the glute and serve the glute, along with many other nerves that here that just aren't shown because it's a reductionist simplified picture. But if I've got a problem here in the SI joint and it's stiff, it's tight, if it's inflamed, these nerves will get a little bit disturbed, impinged, and will refer into the glute, which is why we can often get glute pain with SI problems and, again, very nerve-based problems. If I go back to the picture before, these nerves here also come down through the groin. You often hear that SI joint may give groin pain. And if you differentially diagnose that from a groin strain, this is why. Look at all these nerves that pass right next to the SI joint, squashed up against it with the muscles over the top. They can all get disturbed. So we can get some quite interesting referrals from the SI joint. So let's start then with, it's there to move things. It's there to basically absorb shock and everything else. And because it's a synovial joint, things can go wrong with it. So the first thing that's rather useful is to be able to find it if we're looking at it. Okay, and this top picture is the way you will find it in the majority of people. And I expect a lot of people right now are saying, yes, I know this. A lot of people will have these two dimples here. And funnily enough, they just happen to mark where the SI joint is. So if you're lucky and somebody's got dimples, bearing in mind on 90% of people, you will have to pull the waistband down slightly on their trousers or underwear. So it may not be appropriate to see these. That's where your SI joint is. And that's great because that's a definite way of finding it. if you get someone who has no dimples and they do occur and you're not sure where it is, there's another good way of finding it. I'm going to go back on the slide. Get your hands onto the top of the iliac crest. So place them on top and push them down onto the top of the iliac crest. And look where the iliac crest comes in. This is not the best picture in the world. In most human beings, the top of the iliac crest is level with the L3, L4 junction. On this one, it seems to be more level with the L4, L4 junction. But you can come across, put your thumbs over, and then you can just count down a couple of vertebrae. If you're used to feeling transverse processes or more likely spinous processes, you can count your way down and go, yeah, 3, 4, 5. Okay, I know the SI joint is around this area. You can also feel the PSI if you're very sensitive with your fingers. You can feel that raised section of bone there. And again, if you're not sure where it is, if you can find the top of the pelvis with your hands and trace it round, you will eventually end up on this little pointed section here, same as you might on the front. So that's 2 ways of finding it, but in most people, they are going to have the dimples. And now we can get into it, really. How do we test it? What do we do? Can you test it? Now, this is where all the tests that are available for the sacroiliac joint are not terribly reliable. And one of the problems is, and it's the same with any test throughout the body, is there's so much else around there. How do you know what you're actually testing? So can or can't you test it? You know, I feel after 30 years of practice that I can test it. Even if some scientific studies tell me there's no way with your hands you can feel whether it's moving or not. It very much depends what sort of therapist you are. It depends how that research was conducted. And research on joints, muscles, measuring movement is notoriously hard to do. So it always comes up with results that are quite confounding to what you may find yourself as a therapist. So let's assume we can test it to a degree, but we have other strategies anyway. Just be aware, keep your mind open. What am I actually testing here? We've got all sorts around here. We've got the sacrospinalis coming up. We've got rectus spina. We've got thoracolumbar fascia coming in. We've got the glutes coming across. We've got all the joints of the sacrum, which may be fused or may be a bit mobile in some people. We've got so much going on, but all of those things will have little clues, little injuries, little problems they can get that will help you go, no, that's not the SI joint, that's not the SI joint. The classics, because of where those nerves were that we saw earlier, are disc herniations. Bear in mind how close the SI joint is to the hip in terms of the socket. You know, it's here and just back in here through this hole and behind it, we've got piriformis and things coming in. So it's really quite close proximity to the hip. And if you've got arthritis or wear and tear deep in the hip, it can easily refer through to what appears to be the SI joint. One thing you can do is if someone has been offered an injection at a medical level, the injection will be given to try and reduce inflammation if that is what the physician expects is happening, basically. But as a therapist, that becomes a very useful tool because, firstly, if they've had an injection and it will be guided, because it's a very small space to get into, if you've had a guided cortisone injection into the SI joint and your pain has gone away, we can be pretty sure there's a problem with the SI joint. So the injection itself can be diagnostic. Someone comes in and said, I had an SI joint injection and it didn't work. They've either missed and put it into a different tissue, which is unlikely because it is guided, or it wasn't the SI joint at all. And bear that in mind with most cortisone injections into joints, whether it be the spine or whether it be the SI joint or something else, the shoulder, the knee. If it hasn't worked and it was guaranteed it went in the right place, it tells you it can't be that. It can't be the problem. The trick really is to use differential diagnosis. So if we say it can mimic disc problems, if we say it can mimic hip problems, then we've got too much to fit in to tell you all the tests, but I will alert you to what you can look at. If someone comes in, we think they might have sacroiliac pain, and part of this is they're reporting back pain, we can test. We can test for sciatic nerve impingement. We can test for disc herniation. There's tests for all of these that you can do, and you can count those out. And if they pass those, we're like, okay, it's not in a disc. It's not that. We're starting to look more at the joint. We've got tests we can do for the hip to see if that's restricted, to see if there might be arthritis in there, to see if there's any damage. So when you've got a joint like the SI joint that's very hard to test, sometimes it's easier to test the structures around it and count them out rather than try and make the sacroiliac joint fit the picture. So bear that in mind. There's nothing wrong with testing all the other structures around it to check that they are not the cause. And then we get reasonable suspicion that, you know, the disc isn't involved. And there's two very simple tests for disc. There's the slump test, there's the straight leg raise, and there's also some movements with the body that will move the disc across or close down facet joints, all of which will tell you whether or not the pain is coming in. But I've got another trick for you in a minute about that. And the way I would deal with something like this, if it was very suspicious, and it's just the way I work, but I would work with assess it, test it, do an intervention, whatever it is, stretch, exercise, acupuncture, Reiki, hands-on, movements, whatever it is you do. Do something and then retest it. That sounds so obvious, basically, but retest it. If it's had the desired effect and you know exactly what it is you've done, you've got your answer. If it hasn't had the desired effect, move on. Oh, I was expecting X, Y, and Z to happen. It didn't. I need to treat a different structure. I need to take a different approach. Actually, maybe it wasn't the sacroiliac joint at all, because I know I just mobilized it and it didn't help. Where else can the pain be coming from? So very often, if someone comes to see me, they get on the couch, I'll do something, 5 minutes later, they're off the couch. And I'm asking them to do something, then they're back on the couch, then they're off again, then they're back and off. It's not a relaxing experience coming to see me, because you're going to be on and off the couch, trying to find the aggravating actions. I like to test one thing at a time so that I understand exactly what I've done. And there's lots of things we'll look at later, like the position of the pelvis, what the feet might be doing, what the overall posture will be doing. If you correct them all in one go, and the person says, oh, my SI feels great, or my pain is gone, you don't know what you did. You have to now give them an exercise for everything. You have to give them some kind of rehab for everything. It's very useful if it's appropriate and the person can move on and off your couch without too much pain, to treat one thing with an expected result and retest it. And if it works, great. If it doesn't work, move on to the next bit. However, we're talking about testing the SI joint. We're saying that it's notoriously hard to test, that the tests that you can do are not necessarily particularly reliable. So you can go much more on history and reported symptoms that the client is telling you about. For people who are on the site, then you'll find I'm always banging on about in my little tips and little blogs about really listening, getting a good history, telling, you know, find out what the person's saying. And that saying I often use, listen to what your client or your patient is telling you. They're telling you what's wrong. And even if they don't know the language, they are telling you what's wrong. When a client basically says to me, I have back pain, the first thing I ask them is point to where it is. And if they point above their belt line, then I'm pretty sure it's in the back. If they point below the belt line, there's a darn good chance it's the sacroiliac joint. If they point along the belt line, that's really annoying because it could be either. But I reckon 90% of my people who've come in over the years and said they have back pain, when I say where, they poke their fingers down right, funnily enough, on the dimples. They come down below the belt, they go, oh, here, the sort of top of my backside, and people forget the back comes right down into the sacrum. It's not above the belt. It's what you see as the backside in a pair of trousers is also the back. So that's a classic. There's some other classic things with SI joint problems. Pain when you're sitting. Now, obviously, that can be from a disc as well, but sometimes when you sit, a disc will relieve, but an SI joint will not like sitting. for long periods. It won't like it at all when you rise from sitting to standing. And one of the things you'll get with sciatica and discus use is people will often say, it's much better when I stand up, basically. When someone says it actually physically hurts to go from sitting to standing, it's even worse. You've got a good chance it's a sacroiliac joint, so there's a clue there. And pain going through into the hip or the groin. Because again, if we've got a disc problem further up, yes, we can get referrals through into the front. We can get referrals there. But remember, the majority of the front of the body is served by the femoral nerve, which passes under the inguinal ligament. It doesn't go anywhere near the SI joint. So again, pain into the groin, test for groin strains, test for things, but suspect it could well be an SI joint. And if you have treatment techniques for the SI joint, you may find the groin pain goes away as a result. I've got a list here of the common physical tests that we'd use, and there's loads of them. Okay, these are the ones I see used most often. I'm not going to teach you them. We'd be here all day if I do that. They're very simple ones. They're all, if we wanted to throw real science at it, they're all rubbish because they're not very reliable. If you pop onto YouTube, John Gibbons has got some great videos showing you how to do all these tests and talking a little bit about their limitations, as John does. So that's really good. The one I tend to use the most is the Gillet test. Basically, that's just the one I favor. I just feel I'm very good at reading it fundamentally. As I said, I'm not going to take you through those, but if you wanted to know what test do I use for the sacroiliac joint, how do I do them, just go and look those up after this webinar. Have a look. The videos on them are literally 1 minute 30 seconds long. They're that simple. The stand inflection test I can tell you about so easily. You just put your finger on those dimples. Hopefully they're level when you start, not all over the place. And you ask the person to bend forward. As they bend forward, ideally both thumbs should travel at the same time. If one goes up and one doesn't, it usually indicates that the sacroiliac joint, where the thumb goes up, there's no mobility in it. It's stiff, it's tight, it's just going over with the iliac crest. It's all traveling over together. And the Gillet test works the same way. You're just putting one finger on the dimple and then actually one onto the sacrum and watching if they move in different ways. So just have a little look at those. The distraction and thrust tests, they're more about, is there instability in the joint? So the Gillet test, the flexion test, they look at, is it tight? All right. The distraction test and the thigh thrust and the Faber test, they're telling you more about, is there excess movement? So that's something that I can just simplify for you. Be aware of what those tests are looking at. Okay, what can go wrong with the sacroiliac joint? Everybody uses that term, dysfunction, but that's all it is. It's a term. The sacroiliac joint has gone wrong. It's not working properly. It doesn't tell us anything. Sacroiliac dysfunction is not a condition. It's an observation of what is happening. The things that happen traditionally are the joint either becomes too tight, I spelled too wrong, and it's either hypermobile, in which case we're looking at those Gillet tests and the standing flexion tests and things just showing us that the joint's locked up. There's all sorts of reasons that can happen. And again, you can pick these up in your history, your client in a way, by the nature of who they are, what age they are, what they're engaged in, sports or movement-wise, can all give you clues. Ligaments, joints, they stiffen, they tighten with age. So with an older person, this is likely to happen. It's well documented that after spinal surgery, basically where you've either had a bit of a laminectomy or a disc taken out or part of a disc taken out or decompression or anything like this, there tends to be an increased workload as they try to stabilize the spine, because when you leave your operation, you won't have been given any exercises to re-strengthen the stabilizers of the spine. It just doesn't happen. So suddenly we get an awful lot of load coming into the sacroiliac joint as we try to work around that, and that's very commonly seen. And in that, we just work to restabilize the spine. What is interesting is how the sacroiliac joint works. I'll come to this in a minute. basically. It's important. If we've got overactive muscles on the back of the joint, so around the multifidus, the erector spinae, sacrospinalis, glutes, all sorts of things coming in, they create, and I'll show you a picture in a minute, they create a sort of backward closure of the sacroiliac joint. And that's offset by transverse abdominis and internal obliques at the front, and loads of others, pelvic floor, diaphragm, the lot. They all offset one another and hold the joint where it's meant to be. If one of those sets of muscles is out of balance, it will either pull it too far forward or it will pull it too far back, both of which will represent tightness. The joint is getting compressed either anteriorly or posteriorly. And we need to try and work out which one that is. If that happens, you'll get wear and tear because the joint surfaces are now really close to one another. You're moving, the joint's doing its little rotation, its glides, its backwards and forwards movements, and it's far too tight. The cartilage surfaces are rubbing on one another. It's going to get inflamed, ultimately wear and tear, painful. Bear that in mind because that's how we're going to fix it. And we can go the other way, to lose. Yes, that should say to loose. We've got a hypermobile joint. I see less hypermobile SI joints than tight ones, because we usually have to have quite a few things happen to make something that's surrounded by lots and lots of ligaments, that has a lot of strength and support from its ligaments, to come loose. Something pretty bad has to happen. Now, a lot of women would agree that having being pregnant and having a baby is something quite bad in terms of comfort, basically, but there's a pleasant offset afterwards when you have your child. However, right near to birth, as most of us will know, you release relaxin into the body to help the bones of the pelvis, particularly down at the bottom, open up to help with childbirth. And that does mean that the ligaments that surround the sacroiliac joint do become looser. And this is why we get so many sacroiliac problems and so many lower back problems, so many pelvis problems, particularly in second or third pregnancies, if they're in close succession, where it never really had a chance to recover from the first one. And bear in mind, when you're pregnant, there's an increase in body weight because you're carrying a second person about inside you. And as the baby gets bigger and bigger and bigger, the weight and the pressure down on the pelvis gets more and more and more, whilst all the time the ligaments are getting looser and looser and looser. And hang on to that thought, because when we talk in a minute about how do we restabilize a joint that's become loose, this is a very common thing you may see. And it's a question on all my forms that I ask people: have you had children? It seems like a very odd question at first to a lot of people, until I explain why I'm asking, because that has all sorts of ramifications around the pelvis and what that can lead on to. Traumatic injury, of course, is the other one. You know, big impact through the pelvis, but I'll tell you what, it has to be a pretty big impact to damage the ligaments. If you're going to put so much impact into the pelvis that you're going to damage the ligaments to the point the joint is loose, you're going to pretty much shatter the pelvis at the same time. So actually, we don't tend to see a lot of traumatic injury that hasn't come with an enormous bit of rehab and screwing and pinning and plating back together anyway. But do be aware that kind of level of traumatic injury can also cause it. And guess what? Now, instead of having the joints too close together and rubbing, we've got excess movement in the joint. So we get excess friction and excess movement, and we're back to inflammation, and we're back to wear and tear. So it doesn't really matter whether the joint is loose or whether it is tight. You're going to get some form of inflammation from the rubbing, from the friction, and ultimately that will end up with the wearing of the cartilage. What's important is to be able to work out which one it is, because that tells you what you can offer as a therapist or as a trainer to fix the problem. And that comes back to those tests we talked about earlier. When you choose your tests, when you look at your tests, and the ones you choose to use, just be aware of which ones indicate tightness and which ones indicate laxity. That is probably one of the biggest takeaway points of today. When you test a sacroiliac joint, be aware of what you're testing for, tightness or laxity. It dictates absolutely what you're going to do. Give a tightening exercise or a strengthening exercise to a joint that's already too tight, and we're going to increase the pressure even more. It's not helpful. Moving on. Hey, how do we resolve it? We've looked at what it is, we've looked at what it does, we've looked at why it can mimic other problems. Basically, we're trying to keep life simple. There's a magic word here, forced closure. Now that may mean something to some people, it may not mean anything to others. Joints have two kinds of way they hold themselves in position: form closure and forced closure. Form closure is where the joints are shaped to fit perfectly into one another, and their shape keeps them together. Forced closure is where it relies on the muscles around it to keep it in place. Now, in reality, most joints have a bit of both. The shoulder is a great example of forced closure because the ball is so big in comparison to the socket, whereas the hip is a great example of form closure, where the socket really grabs the ball. But there'll always be a little bit of both. But in the SI joint, there's a massive element of forced closure. It relies on the muscles that surround it to keep it moving in the right way and to keep it in the right position. And this is what I was talking about earlier on. On the next slide, we get something very important. It's the same angle. It's looking down, again, through the spine and the pelvis. This blue lines here are the thoracolumbar fascia, the massive, great big grey bit you see on your anatomical charts on the wall that comes down off of the lats, attaches to the bottom half of the spine and all over the top of the pelvis and right down onto the sacroiliac joint and right down through the sacrum. Thoracolumbar fascia is a major, major, major stabilizer of everything in the spine and the pelvis and everything else. And this is the slide you come back to. When you look at this again, if you want to understand how to treat the sacroiliac joint, it's not about me telling you which exercises to do. It's about understanding which muscles cause which problems, and therefore you know which exercises to do. And if you look at these muscles here, transverse abdominis connects in to the thoracolumbar fascia. Internal oblique connects in to the thoracolumbar fascia. Psoas does, all sorts does. External oblique doesn't. So what we're talking about here, and bearing in mind what's not shown on here, is the diaphragm and the pelvic floor also get involved in this. So everything we would generally term as the core, and I have to do that because the core is obviously quite a contended area. But as far as I'm concerned, what we call the core is actually a whole set of muscles that attach to the spine, the pelvis, into the thoracolumbar fascia, and can be mechanically shown without question to stabilize the whole area. And that's what these muscles do. Anything that goes into the thoracolumbar fascia is a stabilizer of the core, basically. So what we get is the transverse abdominis. There's lots of other muscles. I'm just picking on a few. The transverse abdominis and the internal obliques, they create a forward pull on the sacroiliac joint. If I can go back to the picture before, they would create a pull sort of this way and this way. They'd force it here open, but that would mean the front of the joint here, where I'm moving my cursor, closed. That doesn't happen because as you engage the transverse abdominis, as you breathe correctly, if you do, and as you engage the internal obliques as part of your walking and part of the way you balance your body, then this sort of action that would theoretically, and it doesn't really work like this because it all happens at once, but as those muscles engaged and threaten to pull the front of the joint together and the back of the joint open, well, that's okay, because thoracolumbar fascia and the rectus spinae and sacrospinalis and all sorts of other muscles at the back and multifidus also engage. And they, if they engaged by themselves, would pull these two spines together and open the front of the joint, either of which, if they were imbalanced, would represent or would test as stiffness. basically. So in a nutshell, we need all the muscles to work evenly. And that's very disappointing because everyone wants to hear something more, somehow more clever than that, basically. But your body relies on a fine balance, as we all know, of muscles working in pairs across joints or in groups across joints. And this is a classic example. Now, let's say, for argument's sake, as with a lot of people, we've got some weakness in some of the larger muscles of the core. We've got weak transverse abdominis, we've got weak obliques, we've got generally weakness around there. But we've got very tight back muscles, which we see a lot of as various muscles in the back desperately try to hold the trunk up and whatever. Suddenly, if all the back muscles are very tight, but the muscles around the abdomen and the obliques and the ribs are very weak at the front, well, then we're going to get a problem. We're going to get exactly what I pointed out. We're going to get the joint being forced closed at the back, stretched open at the front, and that's going to hurt, basically. If we had very underactive back muscles, which is almost impossible, but we did, and we overengaged the muscles at the front, we'd create that compression at the front of the joint, the opening at the back, which would pull these ligaments tight, really tight, which would also stop the joint moving. So actually, in a nutshell, I could just say to you one word, core, and press end meeting for all. We have to make sure that our core muscles are working evenly. We've got to make sure there is not excess tension in the back. As soon as we see, for people who've been on things like our spinal and postural assessment course and things like that, and those are all available as webinars, there's all the tests for these to show you what you would see in the back to say that the back muscles are overworking. And for those of you who've seen it and are used to it, you'll know most people come in with horrifically tight back muscles and actually overall a very poor functioning stability of the trunk and the pelvis and the spine, or the core, whatever you want to call it. And those people, funnily enough, will have a sacroiliac problem. And it doesn't matter if you choose to mobilize the joint. It doesn't matter if you choose to massage the muscles that cross it. It doesn't matter if you choose to acupuncture it or give them exercises to mobilize the joint. You will mobilize it at the time. You will get more fluid into it. It will become more mobile. But while those muscle imbalances remain, it'll just come back. It'll tighten back up. Now, the beauty of this and the simplicity of this, and this is what we always do, we always aim to simplify what's going on, is if your joint has become damaged and all these ligaments that hold it together have become loose, or if they've become loose because of pregnancy or something like that, and the joint's wobbling all over the place and that's causing pain, we can't really make the ligaments tighten back up. We can over years and years and years, potentially, but we can use the muscles to stabilize the joint. And funnily enough, it needs to be exactly the same muscles, doesn't it? It's suddenly so obvious. We want the muscles at the back and the muscles at the front that kind of compress the pelvic ring, that create the whole intra-abdominal pressure, that create stability around the trunk and the pelvis. If they're all working evenly, funnily enough, the joint will become as stable as it can and the problem will go away. So suddenly it's not complex. In a way, it's knowing what to treat. Do I loosen it or do I just give strengthening? So these are some of the options you might see outside of what we've just talked about. Hypermobile joint, moving too much. In pregnancy, classically, you'll be giving a belt, an SI belt, sacroiliac belt, that just boom, goes on the iliac crest and forces it all together and basically helps you walk around and function. Because of course, if those joints are too mobile, we said they're part of the way you mobilize and articulate, you're going to get a problem. So you can get that temporarily. Then we need to achieve forced closure. We've got to get, funnily enough, the core muscles working. And as far as I'm concerned, and as far as everybody on this webinar is concerned, go back to the slide with the thoracolumbar fascia and its connections on. They are not in question. Those are the stabilizers. They are the main stabilizers of the spine and the pelvis and the trunk. Forget anything else. These things don't work independently. They all work together. Those are directly observable, measurable, testable things that stabilize the spine and pelvis. That's what you need to be working on. That is what, once you find your way around those muscles, you can use muscle testing, if that's what you do, to say, are all these muscles working evenly? Or are some too tight? Are some too weak? Are some too strong? And then you can rectify that based on what you find. For a hypomobile joint, one that doesn't move, we still need the muscle balance to be right. It doesn't change, but we want to put some movement back in that joint to help just loosen it up temporarily, to help the person deal with it while they're rebalancing their exercises. We don't want to do any of these if the joint is loose, which is why those little tests are important. And as I say, the tests aren't very reliable, so you have to put a whole history together to trying to decide, is this loose, is this tight? But we will have some elements about traumatic injury, about pregnancy, about things that may indicate the joint is loose. If someone says they just feel unstable around their pelvis, or they feel a bit unstable through their hips, that could be looseness through the sacroiliac joint. All I'd say is, if you're not sure, we come back to test, assess, retest. So I could try any of these techniques. I could mobilize the sacroiliac joint manually, because that's part of what I do. Not everybody will. I can also mobilize it by getting someone to pull their knee to their chest, which I'll talk about in a second, often get them to rock their knees from side to side. If the joint is too mobile, do you know what? It will play hell with it. People go, that exercise you gave me, or that treatment you just did, has made my pain worse. And whilst that's not a good thing, do you know what? Actually, it was diagnostic. There, get over it. The pain will go away in a few minutes or a couple of days, and you can go, right, you definitely don't need mobilization. We need strengthening. So again, test, intervention, retest, read the result. Just you get a poor result doesn't mean it's gone wrong. It doesn't mean that you've done the wrong thing. As long as you can read that and say, that shouldn't have happened, that's obviously loose and it didn't like being made even looser, then that's fine. You're not going to loosen the joint anymore. You're only giving it a bit of temporary extra movement as you get synovial fluid into the joint with these exercises. You're not going to cause damage, not unless you keep doing it forever. So the mobilizations, if you know how to do them, are something you would do. The knee to chest, you'll see this as lying on your back, and you bend your knee and you pull it up into your chest, and then you let it go again. And that works. That works when you're lying down. It doesn't work when you're standing, because what will happen is you will ultimately run out of femur movement in relation to the hip. And when that happens, if you want to get your knee to your chest, you have to move something else. If you're standing, you'll just rock your entire pelvis forward to get the extra movement. When you're lying down, your weight on the floor and the fact that the sacrum is now on the floor means that you can't readily rock your pelvis. So you will actually take a rotational movement through the sacroiliac joint to get your knee to your chest. So it works wonderfully as a home exercise for someone to loosen the joint up. And if they tell you that makes things worse, there's your answer. It needs strengthening, not loosening. The knees to the side we see all the time. They're given out for back problems. Lie on your back, knees bent, let them go left, let them go right. I mean, that mobilizes the whole spine, and this is that problem with what else is happening. But that mobilizes the entire spine, but it just does happen to mobilize the sacroiliac joint. But if you can test someone's spinal movements, if you're used to that, if you're used to watching and feeling how the spaces between the transverse processes change, during your testing, you can work out, well, you're really mobile in the spine, but you're struggling to tip your legs left to right because the sacroiliac joints can't do their little anterior posterior movement. So that's a good thing to do as well. And having said that, that would bring us on to, well, what happens when my person comes in and they've had an X-ray, they've had an MRI scan, they've had an ultrasound, they've got a confirmation that they have wear and tear and osteoarthritis in the joint. What do you do? Funnily enough, everything we've just talked about, that's the beauty of it. It doesn't have to change. All we have to make sure is that that joint is as in a good a position as possible, that it's not pinched to close at the back, that it's not pinched to close at the front. basically, that it's not more mobile than it needs to be, and it's not tighter than it needs to be. So everything we've just talked about, and which is almost very little, will sort out nearly every problem, as long as you have established, is the joint moving too much or is it moving too little, basically. If you don't work with this forced closure, which I'm going to call muscles of the core, I'll keep going on about core like that, but if you don't work on the basis of forced closure, you're not going to get anywhere. We're never going to get anywhere. The first thing we have to ensure, it's absolutely 101, is that the muscles that act on the thoracolumbar fascia that attach to the pelvis, which includes the obliques and the transverse abdominis and everything else, they've got to be showing an even pattern. And funnily enough, you know, we have a postural analysis webinar. You can get all these things for 10 or 12 pounds or something. You can buy them all retrospectively. The postural analysis webinar that some people I know here today came on, we looked at how do you assess pelvis position? How do you assess spine movement? How do you assess everything I'm about to talk about in a minute? It's all on that little webinar, basically. But fundamentally, if the pelvis is not level, something's not right. The stabilizers of the pelvis are not working. And the larger prime movers that attach to it, both in the trunk and in the legs, have managed to pull it into a tilt or a rotation or something. So as soon as we see a pelvis that isn't level, and again, people will argue as to whether or not you can see a pelvis that's level, but we can get a rough idea by looking at the SIS, the PSIS, the iliac crest. We can see if it's roughly level. If it's roughly level, things are good. If it's not level, it indicates globally that there's bigger problems behind it. And those bigger problems will by default affect the SI joint because they involve the thoracolumbar fascia. Phew. So we've done all that. Job done. Must be. We fixed them. Of course it's not job done, because what we haven't asked yet is why. Why did it end up tight in the first place? Why did it end up loose in the first place? We've talked about that to a degree, but we haven't really nailed down some of the other things. We've only talked about the muscles that come in around the trunk, the muscles that come in around the pelvis, basically, and are they working? There's other things to check. And again, all these things were covered in the postural analysis webinar. But what are the feet doing? Because as you go through, if you choose to go through some more SI things on the net, whether it's reading it or YouTube, you'll find that leg length difference comes up a lot. And of course it does. If one leg is longer than the other, it's going to put an uneven amount of pressure and rotation through the SI joints, and that's going to hurt. Now, if that's a congenital leg length difference, hopefully the person's going to have some kind of insole or built-up shoe that will level things out and it will never become a problem. However, it is phenomenally common to see acquired leg length differences, which then create a rotation or a tilt through the SI joint, the big one being feet. Okay, and there's a very simple exercise to check if people's feet are actually doing what they're meant to do. You get them to balance on one leg and you watch what the foot does. And then you get them to balance on the other leg and you watch what the foot does. If one foot's going and wobbling and shaking and tipping and going all over the place, there will be some kind of strength issue through the muscles in the foot. And as I say, the postural analysis webinar tells you about that. But fundamentally, if you just looked at it tomorrow in somebody, if the feet generally are either falling in or falling out, and they're not just evenly working between the big and little toe, something will happen to the leg. If a foot naturally overpronates because it's gone weak, which it does after pregnancy because of the problems with relaxing, again, getting into the plantar ligament in the foot, if a foot rotates and overpronates in, it will take the tibia and the femur in with it. And that will have an effective shortening effect on the leg, which will pull the pelvis over. So check the feet. And if you don't know how to check them, make that something you do for CPD. Check the core, or whatever you want to say is the core, but what we've talked about today, check that. Pelvis position can also create problems with leg length. If I've got some kind of imbalance in my obliques and my core is weak and therefore my pelvis has been able to move, if one side of my pelvis moves down, whether it's that way or whether it's a rotation, the distance between the floor and the socket, basically in the acetabulum, has got shorter. And that somehow has to be accommodated. And people accommodate that by, funnily enough, overpronating their foot. They tip their foot in subconsciously to make their leg bend slightly to increase the Q angle to allow for this tipping of the pelvis. Whoa, what's that doing? So the feet can affect the pelvis, but the pelvis can affect the foot, and both of them will give an apparent leg length difference. So if it's not something you already do, make that a little CPD thing that backs up what we're talking about today. And most importantly, the whole body posture and its knock-on effects. Really, again, we've talked about that a lot in the past. Fundamentally, if your center of gravity is outside of the center of your body, if you've got head and shoulders forward, anterior pelvic tilt to sway back, if you've not got your line of gravity falling through the line it falls through on your Wilcott, whoever it is, chart that everyone's got on the wall, there's a plumb line through it. And look at the plumb line of the side-on body and make that something that you compare to every person who walks in your door. That plumb line isn't falling through the ear, the shoulder, the elbow, the middle of the pelvis, the back of the knee, down through the ankle and out through the arch of the foot. You're going to have problems with generally the whole backswing of the body, the calves, the hamstring, the glutes, the back, the neck, everything else is where we generally go as protraction occurs, as pelvic tilts occur, all the weight comes forward. And if we're going to lock up through the back of our body and that body's going to go super tight because those muscles are trying to pull us back upright, it has that direct effect around the thoracolumbar fascia, which then pulls the joint into closure. So we've also got to take the whole body into account. All right, it's hard to remember all, but let's summarize it. It's hard to test the sacral out joint reliably. So assess it, test it best you can, do an intervention, and then reassess to see if it's had the desired effect. Use differential diagnosis to go, I will just count out the back, I'll count out the discs, I'll count out hip problems, so that you're slowly coming in towards their side joint, if that's what it is. Keep a completely open mind about it. Don't get tied up with just the area they're pointing to. Look at the whole body, everything we just discussed. If the body mechanics are out in general, it's always going to end up affecting you around the thoracolumbar fascia because of the nature of the way that the legs pull off of the pelvis to walk, the nature of the way the trunk pulls off of the pelvis to rotate and move and to give you reciprocal action when you walk. It's always going to come back fundamentally, which is why I'm banging on about the thoracolumbar fascia. It's crucial to the way we move as humans, that functions correctly. So don't get tied up in the SI joint. Someone comes in, think about the history, think about where they're pointing. If it seems to be the SI joint, do whichever tests you've decided you've practiced and you like the most. Try and read the results, but do be completely aware of what else is going on through the body, because if that isn't right, you're really going to struggle as well. Does anybody have any questions?
I'll ask a question, Ian. It's probably a bit silly, but
Oh, no, we're not having that. No silly questions. No questions are silly. Please go for it.
Yeah, because I do have a client with a particular, and I asked for this webinar because it's a little bit of a, I don't know, just a real grey area for me, and this has really helped me with the testing side and stuff, and it's just you've simplified it, which has been great. So thank you for that.
Yes.
I get her to do some core exercises on the bed because I've got a fitness background as well, so that's good. So. And when she does very simple core exercises, it really hurts her. So she doesn't want to do it. So what would that be sort of implying then? If those very simple, like single leg toe taps down, you know, anything like that, really simple stuff, it hurts her.
Where did she get the pain?
Around her SI and into her.
Yeah. Okay. What position is she doing the exercises in?
On her back.
Okay. So it may be as simple as the facts, and it's hard to know, but this is what I would initially try. I would take them away from the lying down position, basically, because it may just be the direct pressure.
Okay.
When you lie on your back, depends a little bit on your shape, but either both iliac crests will sit on the floor and then the sacrum will sit slightly off, and therefore there will be a sort of anterior to posterior pressure through the joint. Or in some people, they've got very curved sacrum, and when they lie on their back, the sacrum gets pushed upwards, which is the people who say, ow, it hurts to do a sit-up without a mat or something like that. I would choose a different type of core exercise so that she can do either sitting, perhaps on a gym ball, or something like that, or something she can do standing, something she can maybe do on all fours. That would be my start point. Okay. My initial assumption would be that she lies on her back, she starts to do the movements, because that creates body tension and tone, and through the fascial connections and everything else, it does create movement elsewhere throughout the body. It's a good possibility that the joint's saying, I don't want to have pressure on me and then have you move me around as well. It's only a guess, okay, but that's the first thing I would try. The only other answer to that, and it's so complex, is that it is completely the right exercises for the muscles that are weak.
Yeah.
And that's a minefield, because for a lot of us, when we work the core, we work it as a whole, which makes sense, basically. But actually, if we are good enough with our muscle testing and our history and observation to realize that one set of muscles is really suffering, sometimes actually we have to focus on just those. And when we try to work the whole core, what we sometimes end up doing is just reinforcing a poor pattern in the first place. It's a real minefield, but I'd start with that changing position, because it's so simple. Change position, take it away from what could be direct pressure onto the sacrum, and therefore transmitting through to the sacroiliac joints, and see if that changes things. And if it doesn't, private message us.
I've got a question. I've got a client who's actually a fellow massage therapist herself, and I think it could be something to do with her mechanics, as she's so she's now got a lot of SI pain, and is struggling to even, well, she can't even put her own socks on.
Wow. Okay. Yeah.
So I've suggested to her to change the position of her bed and obviously really concentrate on her mechanics. But I was just wondering what your take is on that.
That's a really interesting one without seeing it. I have to go with what you say. Have you been able to establish, or will you establish after today, whether or not that joint was tight or loose, or are you not sure at the moment, having done this?
I'm not sure at the moment.
Okay, that is my answer to you. My answer is, have a little look back at some of the things I've talked about today. Have a look at the tests for loose. Have a look at the tests for tight. Retest her with that in mind, basically, and see if what you're giving her is the right thing.
Yes.
And that was actually that was almost the basis of this talk.
Yeah.
Is it loose? Is it tight?
Yeah. I think she's probably more than likely going to be tight.
I would say, from what you're telling me, with trying to put the socks on, she is tight.
Yeah.
Most people are tight. As I said, we don't see the loose very often.
No, basically. And she's quite fit, and so.
Yeah, and if it's tight, then we've got to kind of find out why it's tight, and that comes down really to now looking at what position is her pelvis in. Is it level? Is it tilt? It hasn't got an anterior tilt, indicating that apart from the whole kind of trunk stabilization and core musculature being weak, if it's gone forward, the hip flexors and the quads are wickedly overfiring. If it's gone to a posterior tilt, then the hamstrings are overfiring. Both of those things, because they pull on the iliac crests, will put a horrible rotational restriction to the joint. And then if she's posteriorly tilted and you then ask her to lean forward to put socks on, my goodness me.
Yeah.
Well, I can't. I'm already backwards in my pelvis. I'm already overstretched through the spine. I'm already over tight through there. You know, the joints are horribly tight. So have a look at it in that sense. I get a feeling nearly every answer I give is going to be a bit woolly because it's impossible to know without looking, but I have to go with the best guess I can. Yeah.
And just a small quick question. You mentioned about pregnant women. So how after birth, how many weeks do you think is it at their 6-week check or 8 weeks or so, that we would start doing things with them?
You can do it straight away.
Right, okay.
Okay, and if your client is not worried about exercising during pregnancy, and unless they've been told, you know, by whoever they're under not to, there's no reason why they can't exercise and strengthen their core right through pregnancy. Start straight away.
Okay.
It's one of the reasons that the when you go to the antenatal and postnatal talks, the health visitor goes on and on and on and on about the pelvic floor exercises that no one ever does. And the reason they never do them is anybody who's had a child will know that once you've had a child, you don't have time for any of these exercises. You're far too busy for everything else. So it's difficult to fit them in. But no, you can do them anytime, and the sooner the better. And yeah. That's not a problem at all.
Thank you.
But bear in mind that relaxing stays in the system for months after birth, not weeks. So you've got quite a long window where it's going to be mobile, really, where you can get all sorts of problems occur. So yeah, the sooner the better. And if it's during, even better.
Oh, sorry, I just
go on.
Go on, you know, you said it's a synovial joint. So can you get like the like almost like a burster from that? Like, can the synovial fluid come out of that at all to cause like a kind of cyst or anything like that?
I've never heard of it.
No.
And the fact the joint has so little movement, it's unlikely for that to occur. And it's funny because the history of the joint and how it's been examined is until relatively recently, it was considered that it didn't move. Okay, which astounds me because even at the point that it was being said the sacroiliac doesn't move, they knew it was a synovial joint. Well, it's not rocket science. It's a synovial joint. It must move. Otherwise, it wouldn't be a synovial joint. It'd be fixed. And as I say, I'd love to know as kind of live imaging and ability to do that sort of thing with live imaging, MRI and that, if that movement is more than they think it is, because when I test a joint, I do see movement. Now, whether I'm seeing movement in the joint, I don't know, but certainly how I read that and then when I treat it, it is effective.
Yeah.
So if it's not the SI joint I'm reading, there's a movement pattern around there that is indicative. And if you're interested, if you go and read the research, and there's a lot of it, there's very little research about this sacroiliac joint coming in. It's all at a sort of orthopedic level.
Okay.
Not a lot coming in at a therapy level. So the given wisdom will generally be, well, there's not a lot you can do about it. Yeah, we'll put a belt on it, or we'll give you an injection, or we'll give you some pain medication, or you just live with it. The fact that you might be able to somehow strengthen it would not really feature on the radar of an orthopedic person who's dealing with bone structure. The muscles and the nerves don't form part of that orthopedic work. So yeah, just be aware of the limitations of research. Thank you everybody for your presence. I hope you found it useful. I appreciate that I have not really told you what tests to do or anything like that, but you can learn these so easily. You know, you could learn every one of the tests I've just talked about in the next 10 minutes on the internet. We're much more interested in you taking in the bigger picture, not getting lost in the minutiae of things that don't matter too much with what we're trying to do in the real world. So if you sit back through this again, hopefully again, it will just simplify a little bit. It'll make things make sense and make you realize that it's not that hard to find your way around the SI joint, provided you've got the hang of roughly where it is, what it does, and how it works. So thank you very much, and I will bid you farewell.